Good afternoon, and welcome to the Facial Pain Association's Giving Tuesday webinar. We're excited to host a panel of experts to discuss different aspects of facial pain and to answer your questions. My name is Melissa Bombeck, and I'm the new CEO here at the Facial Pain Association. I want to welcome today's experts, Dr. Jeffrey Brown, Dr. Jonathan Greenberg, Dr. Wolfgang Liedtke, and Dr. Raymond Sekula. I will let them introduce themselves in just a minute. I have a few announcements before we get started. We are excited to present a panel of experts for a Q&A style webinar. Today is your opportunity to ask questions relevant to facial pain in an open forum. There won't be a formal presentation. You'll find a questions button in your Zoom toolbar, usually at the bottom of the screen, but it could be at the top as well. Please type your questions there and we'll get to as many as we can in the next hour. Today is Giving Tuesday, which is a global generosity movement and a big part of our giving season. This webinar is our gift to you, and we hope you'll find it helpful. In December, we'll start our Phone a Pain Pal holiday helpline. With the help of over 30 volunteers, we hope to help others living with facial pain feel less alone this holiday season. We are also continuing our conference video series featuring webinars from our 2022 virtual conference. Next month, we'll feature two videos, one on mindfulness featuring Dr. Greenberg, who's here with us today on December 7th, and then one on the personality pain connection, which is scheduled for December 21st. You can learn more about the upcoming webinars and the Phone a Pain Pal holiday helpline in this week's bulletin and on our website at www.facepain.org. We are able to provide programs such as these because of your support. We hope you'll consider making a gift to the FPA so we can continue our efforts serving the facial pain community. Once again, I'd like to welcome our experts. Doctors, if you don't mind giving us a quick introduction, we'll go ahead and start with Dr. Brown.
Hello, I'm Dr. Jeff Brown. I am chair of the Medical Advisory Board of the Facial Pain Association and a neurosurgeon at NYU Hospital in Long Island, New York, with a long-term interest and passion for the treatment of facial pain in all its applications.
Thank you. Dr. Greenberg, do you want to go ahead?
Yeah, hi everyone. I'm Jonathan Greenberg. I'm assistant professor in Harvard Medical School and a research staff psychologist at the Department of Psychiatry at Mass General Hospital. A lot of my research focuses on mind-body interventions and psychosocial interventions for chronic pain, and including some recent work on psychosocial aspects of orofacial pain as well.
Excellent, excellent. Dr. Liedtke?
Hello, I'm Wolfgang Liedtke. Also feel privileged to be on board. It's a medical advisory board of the Facial Pain Association. I am now a corporate scientist physician with Regeneron Pharmaceuticals, where I am in a leadership executive position overseeing development of new therapies for pain, for pathologic pain. And before Regeneron, I was for 17 years a physician and scientist at Duke University, caring for patients with craniofacial pain and researching the condition in my research lab.
Great, thank you. And Dr. Sekula?
Hi, Ray Sekula, neurosurgeon. Delighted to be with you all today. Thank you.
Well, thank you all for joining us. We're really happy to have you here. We've had several questions from the email that we've sent out and from our social media posts, and then we'll be taking live questions as well. So I expect that they will cover a range of topics. The first one that I want to go ahead and ask is for Dr. Liedtke. How and when does somebody decide that a medication is no longer working for them and they need to look at a different option?
That also depends on the intensity and on how disturbing the pain is, where with a pain that is just messing up life fundamentally and to a way that there is no sleep, there is just total preoccupation with the pain. I think that can be just within a very short period, even days. If we are talking below that level, then it also depends on the medication, and there are some medication that need a bit more patience toward coming to that conclusion, because otherwise one might be throwing away or abandoning an approach that could otherwise be helpful, and that we don't want to do that, because there's already significant investment in taking the tablet and probably dosing up, etc. And so it's not one size fits all. Medications that can influence the nervous system toward interfering with plasticity. I tried to find a general headline there, but it's tough because it's the bag is so mixed, and therefore I'd say so the medicine of a type of carbamazepine, oxcarbazepine, and Vimpat, and medicines of a type of gabapentin, Lyrica. With that, I'd say give it at least a month or two before reaching that conclusion, and a month or two at a dose that is the agreed target dose together with a provider. In the previous seminar, I have strongly advocated the use of low-dose naltrexone as an accompanying treatment to go as a baseline with anti-neuralgic therapy, and for low-dose naltrexone that can even be months that you want to see effect. I have also used off-label in my practice at Duke anti-CGRP medication that are injected once a month and repurpose them from treatment of chronic migraines. And with that, those medicines, they are biologics, they are antibodies, and until they really deplete CGRP from the circulation, that could take 2, 3, 4 months until that is effective. So if on a treatment on a CGRP, don't say it's not working before 3, 4 months is over. So there is no one size fits all answer, and I tried to address it a little bit here.
Can I ask Dr. Liedtke, are you advocating that we recommend low-dose naltrexone at an early stage in the treatment of trigeminal nerve pain, not hold back until all else has failed with the usual gabapentin stuff?
That's if there were some clinical trials in that direction, that would be helpful. So there is currently not. So then we can borrow from the experience with other chronic pain, as in fibromyalgia, and in that condition, it seems that an earlier treatment is helpful and warranted and has a beneficial outlook. But then, fibromyalgia is not TN, and so
I haven't asked my patients, but is that an expensive enterprise using this low-dose naltrexone?
No, it's not, because it's made by compounding pharmacies, and then there are compounding pharmacies that make it for 50 cents a day. So yeah. So it's not expensive to do that. And then also low-dose naltrexone in terms of harmfulness is a pretty benign, that is a pretty benign compound, knowing from data.
But I have to confirm that patients cannot be taking any opioids whatsoever?
Opioids would, concomitant use of opioids would annihilate the effect of low-dose naltrexone, because it's just a little bit of an anti-opioid. And then if the big opioid comes in, it's sort of just smashing it out the window. So it's not harming the patient, but it defeats the purpose.
So that makes sense. We have a question about, and I've even heard many patients don't have the shocking pain, but they have more of a dull chronic pain. And so there was a question that came in asking if the MVD procedure would take that pain away. Dr. Sekula, can you speak to that?
Sure. I think, it's just my opinion, but generally speaking, the microvascular decompression is better for patients with sharp, intermittent shock-like pain that's currently classified by the International Headache Society as classical trigeminal neuralgia. Now, some patients can develop dull, more constant pain over time, and they can do well with microvascular decompression. But it's just my experience that they don't tend to do as well if they have more constant pain as at its initial presentation.
Okay.
And
Dr.
I
Brown.
modify comment. Yes, it's clear to all neurosurgeons for now 2 generations that if you have intermittent, what are called paresthesias, meaning a sudden jab and then you're okay, and a sudden jab, you're okay, which is the same kind of trigeminal neuralgia that's been written about for 600 years. Those are the patients, if they have, in my experience, an MRI that shows that there's an arterial or venous loop stuck on their nerve, then they do better. And there's some work by a neurosurgeon in France that says if it's not only stuck on the nerve, but it's indenting the nerve, deviating the nerve, then you do even better than better. But that doesn't say you won't do okay if you have the burning pain. Most often, I think Dr. Sekula will agree, it's when there's a vein and not an artery that you do have the constant burning pain. And it should be differentiated. You still have to have electrical pain of some kind. Burning pain is electrical pain. If you have aching, gnawing pain, you can still, as long as you have an element, a significant element of electrical type pain, you can have a mixture. So you can have stabbing pain and nothing else. You can have burning pain and nothing else, or you can have a combination of stabbing and aching or burning and aching. It's not a simplistic solution like Dr. Liedtke is saying. Everything is more complicated in this world than we thought 600 years ago. Sorry for the long speech.
That is okay. Let's see. There's a question here that says, do you only do neurolysis on a patient that does not have a compression? What is the difference between rubbing and neurolysis?
Let's give that to Dr. Sekula first. These are not the easy questions.
Well, rubbing would be a form of neurolysis. So neurolysis implies that you're injuring the nerve any way you want to injure it, whether you cut it directly or rub it or compress it in some way. But I think the question is not one of exact terminology, but asking, do you as a surgeon do you do a neurolysis, meaning do you separate the fascicles if you don't see a compression? And I think that depends on various surgeons. Dr. Brown and Dr. Liedtke and anyone else can comment. I mean, I'm not doing much in the way of neurolysis procedures, but they're an old procedure revisited, which there's nothing wrong with. But it's there are other ways to injure the nerve that sometimes I prefer for patients, but there are many surgeons who are doing that when they don't see a compression on the MRI and still believe a patient would benefit from that type of treatment. Do you agree with that, Dr. Brown?
Yes, actually, yes. But one thing is that I myself will not operate on a patient if I do not see on the very carefully done MRI, which is confirmed by a very well experienced neuroradiology, that we don't see anything compressing or contacting the nerve. Then I'm not going to offer an operative microvascular decompression and neurolysis like Dr. Sekula says, but more likely, if I need to, for the stabbing pain, offer a ablative procedure, meaning something to injure the nerve, be it gamma knife, cyber knife, balloon compression, radiofrequency, glycerol. So if I don't see it, I'm not going to explore and I'm not going to offer a neurolysis. Do I do a neurolysis? Yes, I kind of rub the nerve at the end of the procedure if it's a more mild compression, as opposed to one where I see a clear arterial distortion, because of the fact that it's known that the likelihood of complete pain relief is a little bit lower. But neurolysis is not something I go in and primarily say, I'm going to operate for a neurolysis, just the way Dr. Sekula said.
Yeah, I don't either, but some surgeons do.
Okay.
Yeah, I can comment on that. To me, that means it's an imperative to do research so that the methods to do something to the nerve, which is sort of gentle injury, just the right dose of doing something to the nerve that sort of rubs it the right way. Can we translate that into what does that mean for the nerve and what type of cells are responding to this approach, and then in a beneficial way? And if we could start understanding that, then we'd have a molecularly defined, or we'd have a way forward that goes beyond mechanical rubbing or other methods that are clear and distinct. But what does it mean at the level of how does the nerve take to that, and can we mimic that?
Absolutely. This was the controversy of Dr. Janetta a generation ago when he said we're decompressing the nerve, and the neurosurgeons said, oh no, you're just mildly injuring the nerve. We know the secret. We don't think you're doing anything different than another form of injury. And that was a huge controversy, which I hope has been resolved.
Well, I would like to reference here the work from the Karolinska group, neurosurgeons that have collected the cerebrospinal fluid during the operation, and they established that the cerebrospinal fluid is loaded with markers of inflammation. So where are those coming from? And those typically made by immune cells. Yet, when I grew up studying medicine, I was taught, okay, trigeminal neuralgia is not a neuroimmunologic condition, and the cerebrospinal fluid is normal. There are no cells in it, no extra protein. Okay, no cells, no protein, yes, but inflammation is there too, and of a particular flavor. So which type of cell what type of maker is responsible for that? And that goes toward, that's the bad actor, and sort of does a rubbing and the limited beneficial injury do something beneficial to those. And that, I think that is type of research done in humans, done in patients, that could perhaps help us get on the right track.
Well, we're getting quite sophisticated, but then if we say that rubbing the nerve helps, doesn't that create inflammation? And shouldn't that hurt?
But there could be the inflammation that is sort of that type, that is the one that promotes resolution, because all natural inflammation comes and goes, and perhaps the mild rubbing, that is equivalent to what you do. You have a skin injury or recovering from just a superficial injury. Mild rubbing is nature's way of enhancing the healing.
Yes, Dr. Sekula will agree. Sometimes we see if an artery is in contact with the nerve, it's actually adherent to the nerve, it's scarred down to the nerve. And I'm wondering if that, in fact, is part of this inflammatory response. Don't you see that often too, Ray?
Yes, yeah, absolutely. And there clearly is inflammation. If one looks for it, one would find it. What the importance of that is, we don't really know. We're looking a lot right now at really what the real role of demyelination is in these disorders, and how important that really is, as opposed to the natural progression of demyelination in cranial nerves in individuals without facial pain. So trying to answer some basic questions, but we've made a lot of progress, but still a lot to learn about these conditions.
Okay, thank you. Let's get to a couple more of these questions. Are you aware of any conditions that cause pain in the distal branches of the trigeminal branches, primarily in the teeth, but it's not a dental problem? In this particular case, the pain becomes worse right after talking.
Maybe Dr. Greenberg could start with that a little bit, and then
I wish I could. Dr. Greenberg is a psychologist.
Yes.
Yeah. So if there's any question about psychosocial, mind-body handling, quality of life issues, living a better life with a pain, behavioral stuff, I'm happy to answer. But I understand that a lot of people have questions about medications.
Okay, I'm sorry, I didn't mean to set you up, but I'll turn it over to Dr. Liedtke and Brown. But example would be person goes in for a root canal, which is always by definition injurious to a branch of the trigeminal nerve. the vast majority of us have that type of procedure. It goes perfectly fine. There's no pain. You know, once you heal, there's no pain. Some individuals with a perfectly well done root canal, I probably see, I don't know, one every week or two, and they have pain, terrible, terrible pain. You fellows want to comment on that?
Yeah, but Dr. Sekula, I think we need that one. I share your experience, and a lot of patients who came to see me was a typical story. Was a female patient who underwent a dental maneuver that was more involved, and it seemed to have gone perhaps a little wrong here or there. So I like to use the convenient term of butchered dentistry that happened to her. And the lady was in her perimenopausal, in an age window of that. And the end of the story is the pain never relents and then blows up and develops into a trigeminal pain syndrome. And that is such a typical narrative for hundreds and thousands of patients who came to see me in my Duke clinics. So that is, there's definitely something where, to me, risks are coming together, which is an injury to a branch of the trigeminal nerve. And the second hit, there is a liability that is this period of hormonal change in the life of a woman, which is in itself not a disease, but when coming together with another factor that could bring things over the threshold. And then once it's over the threshold, there is a threshold value. It's like the barrel is overflowing and the disease is taking hold. And that could also be against the background of genetic factors that make a person more susceptible to develop such pain. So that's how I view this really striking issue to me. And together with colleagues at the University of North Carolina Dental School, and now at NYU Dental School, I think there is one issue dentists need to become more aware. Because for the dentists, even very good, very highly trained dentists, if you mention this to them, they say, what? And it sounds like not really heard. And that resonates with what educational mission that FPA has. That is to sort of chaperone the attention and say, look, dentists, you need to focus on, and the dental curricula need to have that when the young doctors are educated. So they become more aware, do careful anesthesia in a patient who is at risk. And there should also be perhaps clinical trials giving them for a few days some Lyrica and some clonazepam, perhaps a drug for 5 days, and just cover that invasive period of time to shield them from this damage. And if we have true neuroprotective drugs and approaches in the future, perhaps leverage that. But then Melissa's question was toward whether there is a non-neuralgic pain to a branch that is manifesting in a branch of the branch. And what is the experience with that? And so in a neurologist's neuropathic pain clinics, yeah, there are patients coming with that, and they have pain in a branch of the branch, and branch to the teeth are physically big branches, and so they can be affected. And that is, it goes under a medical term of atypical odontalgia, which is just some Latin like atypical, so it's not that typical. And it's a pain that manifests in a tooth, yet the dental substrate is totally clear. And then leads to sometimes they do a root canal on a healthy tooth, and it's like, okay, well, you do another injury in that case. So if you knew that tooth is really healthy, don't do a root canal. And there, dentists can have and do have methods to be really careful about that. And so atypical odontalgia does exist. It is treated like other branch pain, for example, of the infraorbital nerve or supraciliaris, the same standard treatment. And then with the intraoral treatment, there is possibility to do topical treatment together with dentists who make these devices where you have a night guard, a bite guard that is made customized. And then the bite guard has to be made so that it's not super snugly fitting the tooth, but has a little bit of an opening. And in that opening, you can put topical treatments like ointments or jellies. For the most primitive would be a lidocaine jelly that numbs the tooth, and see whether is that helpful. And if that is helpful, then other things could be mixed in there for topical treatment. And there's a species of doctors, pain dentists, whom I have worked with at Duke, and they are at Rutgers University, NYU also, who know what to put into this type of topical formulations other than local anesthetics. And so incubate the neck of that tooth that is an odontalgic evildoer with topicals that help. So that is one flavor of atypical odontalgia treatment that can be leveraged for this condition, unlike, for example, infraorbital or supraciliaris type of branch pain.
I'd like to just chime in and ask I agree with a lot of what Dr. Liedtke says. We all as neurosurgeons know that dental procedures, sometimes I use the word kindle trigeminal neuralgia. And they can be normal dental procedures. Millions of people have root canals, millions of people have dental procedures, but why do some develop trigeminal neuralgia afterwards? I don't believe that it's because of, don't use that word butchered, please. It's a little bit too much, but I don't believe that it's because anything was abnormally done when the dentist did the procedure. I think it's just a surge of electricity, because even today I talked to a patient, it doesn't have to be a dental procedure. It can be a nasal procedure. And I see patients who have nasal septoplasties, sinus surgery, and then develop trigeminal neuralgia pain. It's this somehow related to the surge of the pain, which could be normal pain associated with the operation. I'm going to ask Dr. Sekula, because I know he has something to say about peripheral neuromas as causing facial pain.
Yeah, I agree with you. My experience coincides with yours. I've certainly seen patients who've had a kind of kindling, if you will, without some type of overt injury or obvious injury, but there are obvious injuries that occur. Example would be a patient has an implant and a type of bone substance is put there by the surgeon deliberately to help grow bone. But then it gets kind of out of control, and it actually encases, let's say, the mental branch of the trigeminal nerve. I have a patient like that. And so in those cases, those patients can form neuromas, or these abnormal tangles of fibers that are trying to reform a normal nerve. There are oromaxillofacial surgeons that will go in and excise or cut out that neuroma and then put the nerve back together. What they've told me, and from what I can tell from my reading, is that those procedures work best within, say, 18 to 24 months of the injury. But I can't say that I have a tremendous experience in this area because there's not a lot of those surgeons, in my experience, out there doing those cases. I now work with one. I had one in Pittsburgh finally after many years before I left, who's quite good. So yeah, that's all I would say about it. But you can tell if there's a neuroma. Generally, first of all, you can do MR neurography, which looks at fine nerves, but you can tell if you do a local block, the pain will be relieved for a period of time. And then, it'll come back after the anesthetic is worn off. So, for example, if you give bupivacaine, like a dentist might give, within 4 to 6 hours, that pain will recur. But if it goes away for 4 to 6 hours, you're likely dealing with a neuroma.
Wouldn't you say, though, if you have nerve injury from a peripheral procedure, you should have some form of numbness somewhere, not just pain?
Yeah, I think that's right. Yeah, I think that's
different
right.
Than you had surgery and now you have pain. There's you need a careful examination, which we all advocate for. Someone really needs to do a careful.
No, I would. Yes, if you have numbness after obvious injury, that is a sure sign that the nerve has been injured. But nerves can be injured without leaving behind a numb spot that is clinically detectable. That is, you can do that experimentally in experimental setting, and there's ample evidence from human peripheral nerve injury. There is nerve injury possible that does not lead to numbness. Okay. And where, for example, if you had an injury that preferentially partially injures the C fibers, what that would lead to is like post-injury nasty pain, and then if that injury does not resolve, it would just leave that residual pain at heightened level, C fiber type of pain behind. that could also lead to, like, you could look for itch. And the sign that it's a nerve injury is that it's a distribution of the peripheral nerve or the nerve substrate that has been injured, like the root in a DRG mediated pain. If the root is injured, you get a segmental pattern. If the sural nerve is injured, you get a sural nerve pattern. And if that fits, that's together with the right type of history, pain there in that distribution, that is sufficient to call it out as a injury associated nerve pain. And you would apply the same laws and rules to the trigeminal territory, and therefore, numbness, post-injury numbness is not that what rules it in or out. So that I think that the entire story and case has to be viewed together with clinical exam. If a dental procedure is done really well, nice, everything according to how it.
Oops, just lost you.
We lost your audio, Dr. Liedtke.
Genetic predisposition, whether there is genetic predisposition to it.
From Dr. Kahle. Dr. Kahle has pioneered these genetic studies, published in a nice paper that's out there, where he shares the genetic roots of trigeminal neuralgia. And I saw numerous families with familial occurrence of trigeminal nerve pain with neuropathic pain and neuralgia. And I said, the textbook saying there is no genetic predisposition. I said, that's wrong, must be wrong. So Kahle's paper is the first one documenting, and others have now followed. So if somebody has predisposing genes, then I could see that easily you have a dental procedure, and that is enough of a trauma to bring that out and over the threshold.
Interesting.
Which is another part of research where I think we are waiting to learn many more things.
So lots to learn. We do have a question for Dr. Greenberg, so I'm going to go ahead and ask it. Dr. Greenberg, what are some techniques to help overcome the fears that many TN and facial pain patients experience with this condition? Because they often cause isolation and depression. So how can people manage that?
Yeah, that's a great question. First of all, I'd like to say how widespread and prevalent and normal that is. So we had a survey of members of the FPA, and we had a sample of more than 300 participants. I think 73% of those had significant clinical symptoms of either anxiety or depression. 1/3 of the sample was taking antidepressants. So living in constant fear is very prevalent in multiple types of orofacial pain. I would highly, if you find that you're very much disturbed by it and it's actually disturbing your day-to-day function, I would highly recommend reaching out for professional help, consultation. It could be a social worker, it could be a psychologist, and there also there's self-help. I'm a big advocate of mindfulness practice, which can help with accepting the pain and kind of living a better life with the pain rather than diminishing the pain. Because a lot of times the pain is just there for years and years. So yeah, anytime you find yourself amplifying the pain, we call it pain catastrophizing. Pain catastrophizing is really one of the most robust predictors of pain. It mediates the effect of anxiety on pain. So anytime you find this little voice in the back of your head saying, "I'm not going to recover. This is not, this is going to ruin my life. I'm never going to be able to do anything again," just tell yourself, "Oh, I'm now noticing that little voice telling me that again. And also, I'm getting the best treatment that I can. I'm seeing the best doctors that I can. There are still things that I can do in my life that are important for me. Hanging out with my loved ones, doing things that are valuable to me, still engaging with my hobbies. Is there anything that you can do?" Like social engagement, it is so important. Getting social support is extraordinarily important for quality of life and well-being. in chronic orofacial pain. And the initial tendency is to do exactly the opposite. Whenever we feel fearful, we tend to isolate ourselves and kind of curb our activities and limit our activities. And so our world gets smaller and smaller and smaller and smaller. And we think we're doing ourselves good because we feel kind of safer when we limit our lives. But in fact, doing that for a prolonged period of time can, it can cause harm. It can amplify mood disturbances. It can amplify our anxiety. And in the long run, it can also perpetuate disability because we do less of the things that can help us. So I would highly recommend reaching out to professional help, engaging in practices such as mindfulness, seek out cognitive behavioral therapy when appropriate, noticing that little catastrophizing voice in the back of your mind, re-engaging in activities that are meaningful and important, and seeking out social support from loved ones. These would be my main recommendations for that question.
Great, thank you very much. We have a question. It says, for those with more constant burning pain, can you explain the difference between TN type 2 and PTTN? And also, is there imaging that would be most helpful in diagnosing PTTN?
I've never heard of the acronym PTTN. What is that?
It doesn't explain that. So let's ask the person who asked that question to.
It's post-traumatic trigeminal neuralgia.
Oh, maybe that's
I'm
it.
not sure though.
You take it.
Oh.
We can, I don't know, is there a difference between TN type 2 and is there post-traumatic TN?
Well,
We can move on from that
yeah,
question.
TN type 2 is a part of a classification system developed by Dr. Burchell, which is part of a statistical construct. So there really is no such thing as TN type 2 versus TN type 1. I know that's really confusing for participants, but that classification schema will likely go away in the next 5 to 10 years because it's really not accepted outside of the United States. And again, it's mostly a way to look at something statistically. So there really aren't patients who can say to you, well, 51% of my pain is constant and 49% is intermittent, so I'm type 2. But that's what that is. But certainly, if in fact this individual means this PTTN to mean post-traumatic, then yeah, that's very different than what type 2 TN was meant to be. That by definition was a type of pain that develops that's more constant with no preceding trauma to the nerve.
Okay, he clarified and said post-traumatic trigeminal neuropathy.
Right.
Yeah.
So along the lines of what Dr. Sekula is saying, as I said earlier, I personally try to stay away from that term or the term atypical. And so there's a variation in the symptoms. One can have the intermittent stabbing that I call paresthesias and only that. One can have the constant burning and only that. One can have a combination of stabbing and burning. And then in between, and I see this in almost all my patients, if they fill out a questionnaire with words to describe what they're feeling, they'll have pain that's not nerve pain typically. Wrong word. That's not described as nerve pain. They'll say they have aching pain and gnawing pain in the middle of paresthesias, stabbing, or burning. So exact descriptions of the pain are very hard to come by. One has to make a judgment based on experience as a neurologist or neurosurgeon as to what exactly is going on. But no, I agree with Dr. Sekula. Please don't ask me to define you as type 1, type 2, or atypical. I will call you as trigeminal neuropathic pain. It's a personal way of just taking, it's a basket, not an individual set of 100 different diagnoses.
So I can give 2 or 3 quick example from my practice where I remember a patient of mine with a post-traumatic trigeminal nerve pain after a injury as a soldier for our forces in Iraq, and he got close to an explosion and he got a blast injury. And so no bone was broken, no he was left unconscious, so the blast knocked him out and over. And then when he awoke, he had a trigeminal a deficit in forms of a paresthesia in the first branch, and then also had a nummular area where he felt hypersensitive and felt a burning pain constantly. So there, in the absence of this bone fracture, a trigeminal pain syndrome came about after explosive injury with IED, an IED explosion, this borrowed in a way a borrowed trauma to the head. Another is the plain and simple severing of crushing or partial severing of branches, as happens in traffic accidents or with altercations with knives, as I have seen. And I also have seen very bad whiplash injuries that then have facilitated a more benign or there was trigeminal pain to a minor degree. And after that whiplash injury, it was blown up and over. And that to me also counted as a post-traumatic trigeminal nerve pain in the form of neuralgia that had become really bad after the whiplash. So as an example of PT, post-traumatic. But as we use the acronym here, PT, I wanted to ask Dr. Greenberg, can you see that there is a sliding scale between catastrophizing in something that looks like PTSD, or would you always strictly separate the two? Which is interesting to discuss, but also has consequences how we treat.
Yeah, that's a good question. To my knowledge, pain catastrophizing has a lot of correlations with multiple kind of pain outcomes, including pain-related interference, pain intensity, and even anxiety and depression. I'm less familiar with regards to specifically the effect of PTSD and its relation to orificial pain within the context of pain catastrophizing.
To me, it is if some human being lives with little or no pain and then is hit with supramaximal pain that without medication makes them think of taking their own life, is that not worse than a helicopter is coming with napalm? And again, so there is learning, but in a bad way. So that sets up the stage for PTSD. That's it.
Yeah.
But has that been researched? Has that been looked at? What's the point of view from a psychologist, as a clinical psychologist, also as a research psychologist?
Yeah, and so there's definitely is the fear of recurrence and the fear of pain, and that. We see a lot of times that, especially when the pain comes kind of unpredictably, when everything is good, and then there's an unpredictable shot of pain. And so you live in constant fear that it's coming, or that might be the beginning of it, and that you would just become preoccupied.
Fear of the fear, and the fear of the fear makes the pain more likely. So
absolutely.
I'd just like to put my philosophy in that. Lots of people have injuries to their face. Every time you have dental surgery or nasal surgery, that's an injury to your face. A blast injury is another form of injury to your face. Getting hit with a baseball, as we all do in children, is an injury to your face, and it hurts. But the pain almost always diminishes over time. What's different about the patient where the pain does not go away and turns into this electrical quality that persists? So in my philosophy, I would always look in that kind of patient with a careful MRI to see if they had a predisposing arterial compression neuropathy. And this kindled again the problem. But the problem wasn't the fact that they were hit, that kindled it. They should have gotten better. Most of us all do get better from such injuries. Some people are different. And so I need to look, quote, deeper. And that's what I would do as a neurosurgeon.
Wonderful. Thank you. We had a question, and we hear this question a lot, but do trigeminal neuralgia attacks get better or worse during pregnancy? Is there any trend either way?
Most of it, the majority I have seen got better.
Really?
But that's my over the thumb. Yeah.
Mm-hmm. Dr. Sekula or Dr. Brown, do you have an opinion?
Mine's just an opinion because I don't I don't know of any good natural study of that, and I don't see the
No, that's your office. The natural study is your office, where you have such a flow that you could judge that. I don't think there is good papers on that, if I'm not mistaken.
I just mean you're right. We could, and we've got lots of different studies going. It's hard to do everything, but I don't know of one. I only see the numerator. So, and with those patients, which is not common, we'll take them to the operating room and do something percutaneous and ablative.
Let me modify the question. Maybe I can ask Dr. Sekula first. What do you do with the young woman who is pregnant and her trigeminal neuralgia is not being well controlled with medicine? Or take it to Dr. Liedtke. What do you do with the young woman who's pregnant and needs to be on medication? Which is the best medication? So it's two different questions. First, what's the best medication? Let me ask Dr. Liedtke. And I think that's important. And second, I'll ask it before answering it, is what do you do with the patient who's not well controlled with medicine and who's pregnant? Is there an easy way to deal with it? First, the medicine question for Dr. Liedtke. Is there a best medication for a woman who is pregnant with trigeminal?
Yeah, so we exchanged on that, and I said that the valproic acid is definitely out with data, but then other anti-neuralgic medications have been looked at, and they appear to be less harmful and less bad as assumed 10, 20 years ago. And so my answer was and still is that I'd say I would go with gabapentin or pregabalin, which is Neurontin or Lyrica, plus as needed low potency opioid on an as needed basis for peaks. And then I also mentioned that next in line to that is sodium channel blocking medications of a type of lacosamide / Vimpat and oxcarbazepine, carbamazepine, and especially the latter two. The record for those in larger studies has been cleared, rather than the initial caution that I learned during medical school, which was way ago. So.
Let me toss the other question to Dr. Sekula first. The young woman whose medicine isn't controlling it and is.
Well, I don't like to do a destructive or ablative procedure on someone who's younger if I can avoid it. But in this case, I probably can't. I can't avoid it if they've already had maximum medication therapy. So in that case, I would do one of the percutaneous ablative procedures, such as glycerol or balloon or something like that, or a steroid block, something of that nature.
I actually agree and have done this. And what I try to do is make as mild an injury as possible to tide them over for the pregnancy, assuming that the pain is going to come back in a short period of time, and then deal with it appropriately once the child is delivered.
Yes.
Glycerol is rarely permanent, right? So that's in a way, an old-fashioned agent, but also has that feature.
What was that again?
Glycerol is rarely ever a permanent thing. It just lasts for a while. If it works well, then it works well, but there is a limited period of time that it works well, right?
Yes.
Excellent. I have a question about bilateral glossopharyngeal neuralgia. Some literature refers to it as vago glossopharyngeal neuralgia. This patient or person is wondering if any of you have experience or have operated on patients with that. Dr. Sekula?
Sure. Well, the distinction with vago glossopharyngeal neuralgia versus glossopharyngeal neuralgia is that the condition is accompanied by vagal symptoms. So, for example, the vagus nerve has some control of blood pressure. So, if a person were to have severe throat pain from the glossopharyngeal neuralgia, the theory is that there's activation of the vagus nerve as well, and that you'll have some slowing of the heart rate and maybe a dip in your blood pressure, that type of thing. That's where the term vagoglosopharyngeal neuralgia. Most often, like trigeminal neuralgia, it's a unilateral condition, but yes, I have treated it on both sides. And I would almost always treat it with microvascular decompression. And unlike trigeminal neuralgia, for patients with, glossopharyngeal neuralgia that's due to a blood vessel, there's almost no recurrence rate to it. So I would not do anything purposely destructive to the nerve unless I had to. That's just my opinion.
We're agreeing a lot. There's nothing that has zero recurrences. I've seen patients that have what are called recurrent glossopharyngeal neuralgia, but it was actually the operation really didn't do a sufficient job. So it's not really recurrent. It just wasn't fully treated. Another aspect to vagoglosopharyngeal neuralgia, and probably Dr. Sekula will agree, is when an artery lies on the glossopharyngeal nerve, it doesn't just touch the glossopharyngeal nerve. It also lies on the fibers of the vagus nerve, the lower fibers, which provide sensation to the throat. And when the neurosurgeons have done sectioning of the glossopharyngeal nerve, they know to partially section those sensory fibers of the vagus nerve. So that's, in that sense, when we decompress for glossopharyngeal neuralgia, we're decompressing for vagoglosopharyngeal neuralgia. The artery doesn't just touch the glossopharyngeal nerve. It lies on that whole fan of fibers anatomically. And one other element of it that I have seen is dysphonia, meaning hoarseness to some extent, because the vagus nerve controls the vocal cord, and you can get a form of hoarseness that can improve with the operation for glossopharyngeal neuralgia, which is not the operation for glossopharyngeal neuralgia. And there have been studies that neurosurgeons have operated for hoarseness by decompressing the vagal nerve. So it's an interesting entity, but I believe that it should be always called vagoglosopharyngeal neuralgia.
Yeah, it almost always is.
Well, I had a patient who developed a glossopharyngeal vagal nerve pain syndrome after a band surgery for an obesity surgery of banding the stomach, like the low-level bariatric surgery. And the key there was that the gentleman was complaining about pain that was shooting into his the tragus of his ear. So that I got it that it was not so clear what's going on, and is this pharyngitis or what is he really suffering from? But then they had shooting pain into the tragus, and that's how the connection was made. And then a decompression where the band was irritating that vagus, then that did it. And other than that, with vagal nerve involvement, I have always wondered, why is the vagus that does way more than the larynx and the pharynx, and it does the colon to a part of the colon. That's how far it reaches. And with vagal nerve pain, I have wondered why is there not more intestinal involvement, lung involvement, and airway? And that I'm a little bit at a loss why that has not happened more in this condition. But then trigeminal neuralgia is a rare disease, glossopharyngeal even more rare disease. And so with bilateral glossopharyngeal, honestly, I was just trying to think about, I could not remember a bilateral glossopharyngeal. If that were presented to me, I would also very carefully look whether it is rooted in a demyelinating disease, which bilateral cranial nerve pain is a mandate to be very thorough at going after that type of a disease to make sure that it is underlying or is not underlying the bilateral pain condition.
I would just add that there's a reason why the vagus nerve is called the vagus nerve. It is, in fact, a grammatical use of a very vague series of symptoms associated with the nerve. So yes, they need to be looked at carefully. And no neurosurgeon thinks of looking at the colon when they're treating glossopharyngeal neuralgia, but that might be something interesting to look at.
It might be subclinical and it's not noticed underneath that horrible pain, that there are other things that are also affected and the pain is so horrible you don't notice it.
Autonomic changes. There are a lot of autonomic changes that go on with the trigeminal nerve that I've studied in the past. And I should write about, but trigeminal neuralgia, trigeminal nerve injury has autonomic changes a lot associated with it if you're studying injury to the trigeminal nerve. We as neurosurgeons know not to push on the nerve too hard because it causes the heart to stop, for example.
All right, we are getting to the end of our time. I'm going to ask one more question to Dr. Greenberg, and then I'll ask one last medical question. But Dr. Greenberg, there's a question here about a patient who visits Facebook pages for trigeminal neuralgia and gains a lot of support from those pages, but then also can sometimes be very devastated by some of the stories that they, that they read, people who are really struggling. And so how the person hasn't been able to really give up those pages, but is just looking for a recommendation. Should they stay away from them? Should they, how should they manage that, kind of walking that line and looking for that support, but not getting just dragged down into the depths that can be really bad?
So we find that it is very helpful for many patients to connect with other people who are going through similar conditions, who really know what they're talking about, especially, for conditions like trigeminal neuralgia or kind of like orofacial pain that's not medically explained. A lot of times these people feel that they're not being believed, or that they're kind of malingering, or they have some secondary gain. And that can be very isolating, and connecting with other people who have similar conditions can be very, very helpful. Now, of course, that can involve exposure to pretty, sad stories, and it can invoke what we call empathic distress. Right? We kind of see how other people are suffering, and that can invoke some distress within us, which goes along with the territory, because a lot of time we seek this support because we feel distress ourselves, and then we connect with others, and then we see how distressed they are, and that kind of evokes the distress that we find that we see within ourselves, and it goes along with the territory. So if we find that it's overwhelming, we can stay away, but we find that when people connect with others, it can be a very invaluable source of support, which is very rare for many of these patients. So there's no one size fits all, as we said before, but especially over the web, and especially for the rare conditions, it's so hard to find support on these rare conditions, but an online group can be a very valuable resource.
I will largely echo that with years of experience and patients feeding this back to me. But there is one particular issue, which is, I would call that a form of a bias, information bias or severity bias, in that patients who are suffering more and don't get answers to their serious and justified question they go from doctor to doctor and it's still not resolved. Then they tend to the internet and say, somebody might know, and they lay out their case, how bad they suffer. And those stories are more negative than the average. And if for example, if patients do better, which also happens, that they are not, that is not the same answer that they go back and tell the world every day and say, hey folks, listen up to this, listen up to this. And
happy stories don't make the headlines.
Yeah. So it is an important factor that has influence on this field. But other than that, I think I would say that web-based communication worldwide is helping patients with rare diseases and patients with horrible pain even more. I think as a bottom line, I'd agree with that.
Excellent. And Dr. Liedtke, I know you have to leave. Go ahead.
Go ahead. I think that's a good way to end this discussion, saying things like this make a difference. Things like the Facial Pain Association make a difference. That's why we're here. That's why you're here. And I hope we can continue this effort in the future.
Excellent. I agree. I think that is a wonderful way to end the presentation. Thank you so much, doctors, for your time today. We're grateful. I know there were a lot of questions that we didn't get the answers to. We will be doing another virtual conference in the beginning of next year. We don't have dates yet for that, but that will be coming, and we can look at answers to as many questions as we can find then. And we'll also be continuing to release our our conference presentations from the last conference. And then there's information on our website as well, which is www.facepain.org. So thank you again for everyone who attended. And thank you, doctors. We really appreciate your time today.
Thank
Thanks
you
very much.
Great to be with you.
Thank
All
you.
right.
Have a wonderful
Bye-bye.
day. Bye-bye.